Good morning, ladies and gentlemen, members of the media. Welcome to the press conference hosted by the Ministry of Health and Wellness today, Thursday, June 20th. The Minister of Health and Wellness, the Honorable Christopher Tufton, is joined by Permanent Secretary, Mr. Dunstan Bryan, Chief Medical Officer, Dr. Jacqueline Biseso McKenzie, and other members of the technical team at the Ministry of Health and Wellness. Thank you so much for joining us this morning for this press conference. We'll begin our press conference with a statement from the Minister.
Thank you very much, Stephen. Let me say good morning to all online and to my team. And let me apologize for my absence from the team and what would have been a live press brief if I was not incapacitated. So I'm actually speaking from home, maybe a little clumsy in terms of filtering through all the stuff that I have here. But nevertheless, hopefully the discussions will proceed anyway. A number of persons are online. The team that Stephen would have introduced, but I believe also we have Dr. Frey from Western Region, Cornwall Regional, who has a sort of overarching responsibility and can comment on that Falmouth incident if necessary. I believe Dr. Bradley Edwards may be online from Maypen and the rest of the team that are here. So let me begin by saying that much has been said in the news recently on issues related to health. We take these comments always seriously, and to the extent that they have had negative consequences on patient care, on the mindset of the population, it is always, from our perspective, important to observe, to listen, and to respond. Sometimes it's a matter of clarification when questions are raised. Other times, of course, we have to address what could be even mischief in terms of some of the comments and the conclusions that have been drawn. So I welcome comments. We welcome comments always. I want to just highlight that in regards to some of the specific issues that have been raised over the last few days, and yesterday included in the press brief by the opposition, that, and this is a more general statement, you may recall that the ministry, through my intervention in the sectorial, tabled a number of documents as part of our efforts to transparency and providing information to the public around what is happening in health. We have limited time to speak in the budget, in the sectorial. So we have taken the approach to tabling a number of documents. And those documents are essentially to give a much more fulsome picture of the state of healthcare, the approach, the methods of response, the achievements, and even the challenges. And, you know, I think this is one of the first times that an administration has taken this very open book approach. The one such document is this document on maternal mortality. And we'll come back to that. But I just want to make the point that the issues raised aren't a secret. And indeed, the ministry took a position that we needed to put those issues out there. And so, you know, it's not a discovery. We're not seeing it for the first time. And indeed, we're the ones who have made it available to the populace in the interest of transparency. As a consequence, therefore, we have no issues, whether with a journalist or with the opposition or with any member of civil society, raising any issues of concern that is contained in the documents that we put out, and that is on our website. And a number of those issues have been raised. And so the intention, therefore, is to address the issues and to clarify where necessary. But I want to begin with the issue of the ventilators, because that has generated some public interest. Let me start off by saying that we have done an audit, as I have said we would have. That audit has provided for us with specific data, all the ventilators that is in the public health system. Based on that audit, there are no ventilators that are missing. There are, therefore, should not be any speculation or indeed insinuation that somehow ventilators are not being utilized. And we will provide on our website just after this event a list of those ventilators and the appropriate serial numbers. And we went, and it took some time, we went beyond just identifying ventilators that are active, those that are being serviced or to be serviced, but also went to the extreme of even identifying those that are obsolete and are not being used anymore, because in the public system, you have to store even the things that you're not using. There's a process, a long process of getting rid of those products. But I think in the interest of transparency, we went the full gamut because of the speculation surrounding the ventilators. There are 210 ventilators in the public health system. And as I said, a full listing of that will be placed on our website. Of that number, 118 are as of the end of that audit in active use, 118. 40 are going through a process of maintenance for one reason or the other, routine maintenance, taking out of service for maintenance, a very complicated piece of equipment. And in some instances of that 40, some are waiting on parts for servicing. The rest are obsolete. They are not functional. They can't be used. And so there's a process that is involved in getting them out of the system. So in a sense, 118 as of the end of that audit are being actively engaged in the public health system. I reiterate what I had said earlier, that this represents the largest number of ventilators that public health has had. And we did benefit from donors. We did benefit from support of the private sector because of COVID. So COVID was an extraordinary period. And as a result, a number of ventilators were added to the process, including the Promac program, which was unveiled during the COVID period, which I'll get back to. So I say without fear or favor, and I ask anyone who has alternative knowledge or data, at what other point has public health has in active use as much as 118 ventilators? I know of no other period, and I've done some checks. And if you add the 40, which will come back in operation at some point, either from maintenance or from parts to be replaced, that even adds to a much larger core of ventilators in the system. I know of no ventilators in a box. There were some ventilators that were received as a gift from the Saudi Arabian government, I believe. The CMO can comment more on that were not able to be used because of technical issues. It was not, as I understand it, as is being alleged, as a result of a lack of training. So I want to clear that up and make that very clear. So in summary, as it relates to ventilators, we have ventilators. They're all accounted for. They're in the public health system. They are being utilized to save lives on a daily basis. And there should be no fear by the public that somehow they have gone missing, as is being explicitly or insinuated by the opposition over the last number of days. And in the interest of transparency, given the public interest, we will make that data available on our website. I want to raise one other issue on ventilators and ask the CMO. I see people making calculation as to 118 divided by 24. It means each hospital should have X amount. That's inadequate. A number of ventilators for 3 million population, that is inadequate. I mean, there there's a clinical justification for ventilators, how they are located, how they are utilized, what are the support systems that are necessary, why there is a referral system from one hospital to another. And this is a good opportunity to have that kind of understanding so that the public is not misinformed or create an impression that could lead to a wrong conclusion. And so I'm going to ask the CMO, Jacqueline Bisesa-McKenzie, to take a minute or two just to explain how we assign ventilators and what are the supporting infrastructure and how the health system is structured in order to determine where ventilators go. CMO?
Thank you, Minister. First, I would want to say that our health system is built on a referral process. We have 24 hospitals across the country, but they are at different levels. And the lowest level hospital offers basic care, and persons are transferred to the next levels depending on the kind of support that they need. And that support may not necessarily be only in terms of infrastructure or equipment, but critically, it is also important in terms of the kind of staff, the kind of multidisciplinary care that is needed to support some patients. So you find that our high dependency and intensive care units are placed in our hospitals that would have infrastructure and equipment, but would also have the different types of staff to be able to offer different kinds of care, because one person who requires intensive care may require different types of intervention based on what is happening to them. And a person who requires intensive care or high dependency care is really a patient that is critically ill, that needs to be observed continuously, monitored continuously, in order that responses can be made to changes in what is happening to them and to support them until they get out of this critical stage. Now, not all patients who require intensive care or high dependency care need to be on a ventilator, because they may be breathing on their own, but they require that kind of support, continued observation in order to monitor their illness. Patients who are placed on a ventilator are patients who are in what we call respiratory failure. They are either unable at all to breathe on their own, or their breathing need to be supported because their breathing is not able to have enough kind of air exchange to allow them to support life. So you have persons who may be on a ventilator or may need to be on a ventilator, but then they would have to be transported to an area where they can be monitored and observed, as in a high dependency or an intensive care unit. So I just want to make it clear that being on a ventilator is one thing, and persons who are on ventilators will need to be in that kind of situation, but it's not everybody who needs intensive care needs to be on a ventilator. Intensive care requires not just a ventilator for those persons that are ventilated, but also it requires all the different types of equipment to support them: monitors, suction machines, infusion pumps, etc. And most importantly, it needs staff. It needs the critical care doctors. It needs doctors from different disciplines, and it needs critical care nurses. So the critical care nurses are vital. And if it is that we have 60 or 70 ICU or HDU spaces, then we need 4 times that amount of nurses to be able to support the patient on the 3 shifts and to allow for them to have breaks. So it is difficult, even with the amount of high dependency and intensive care spaces that we have, to maintain all of these spaces because of inadequacy of staff. And we know that that is a critical factor in terms of our migration problem, where it is that especially our trained specialist nurses tend to leave the country after a while to seek better lives, better opportunities. And that creates a problem in terms of us able to maintain spaces. So sometimes it is that you may have a ventilator available, but you are not able to support the patient in an intensive care setting because of staff problems. So essentially, Minister, I hope I've answered your question in terms of who needs ventilator support. That is persons who cannot breathe on their own, and we have to use a machine to breathe for them. That is the ventilator. And the difference between just having ventilator support and being in an intensive care setting, because a ventilator alone does not provide that kind of high dependency or intensive care that is needed.
Thank you. Thank you, CMO. All right, so I guess questions may follow after, but I just wanted to give a clinical perspective that a ventilator on its own is not the solution. We do have ventilators, but it has to be supported by an infrastructure, and hence why we have referrals. So you move a patient from one place to the next depending on the need, to ensure that the full system is supported. But just to summarize, there's no shortage of ventilators in the system. We have more than we have ever had in active use, even the 118 that I have listed that will be on the site after, plus the 40 that is being revolved in terms of maintenance. And so any fear that somehow they have gone missing is unfounded and exaggerated. I want to just quickly go to Promac, because that issue was raised by the opposition. And there was an impression given that somehow this program has failed to deliver. And that's rather unfortunate, because this program was developed in consultation with our partners, the European Union being, of course, the primary partner. And the quotes from the European Union, I have one here, who themselves did their assessment, and they're very rigid in their assessment. This is a quote from the then EU delegation head, Ambassador Walaska, who lauded, and I'm quoting, Jamaica's achievement. And she said, "As we approach the end of this groundbreaking program, I'm pleased and excited to say the outputs are significant." And it continues. It's an article by Peter Gay Hodges, June 15th, 2020. So the program set out to do a couple of things, and we need to be fulsome in the explanation. You can't just take a piece and then draw conclusions inaccurately to serve particular narrow ends. The program did a couple of things which I'll outline. It clearly was aimed at reduction of maternal and child mortality. It was established to establish dependency units, high dependency units at Bustamante, Victoria Jubilee, Spanish Town, and St. Anne's Bay Hospital. And there was a price tag of that at $822 million. That establishment was as much a physical structure in some instances, renovating an area or building a new structure. It's quite evident if you go to St. Anne's Bay, the structure is there, beautiful building. Spanish Town, the structure is there. The other areas, as is the case with the two I just mentioned, benefited from significant equipment. And let me go through some of those equipment. 6 new ambulances to Mandeville Comprehensive Clinic, Anota Bay, St. Jago Park, Savlamar Health Center, as well as Alexandra and Shepparton Community Health Centers. There was a price tag there of 95 million Jamaican dollars that has been spent, and those ambulances are in circulation. More than 1,800 professionals were trained in neonatal and maternal skills. That training did take place. I went to a number of the graduations, so we did upskill our staff to support this program. 3 campaigns launched to promote the improvement of health-seeking behavior and patient rights, in addition to 29 ventilators to treat intensive care patients that was added to the system. Now, here's the context which is missing from the narrative, which has led to these faulty conclusions. When the Promac program was launched, and indeed the timing was quite important to the Jamaican population, and the ministry and the government, to divert some of the critical resources from the original intentions of Promac to support the COVID response. And for 2 years, the program focused on COVID. So those beautiful structures that were built were used as isolation wards to save hundreds of lives. Patients were placed who were infected with COVID, who had to be ventilated, who had to be isolated. Remember now, we had built COVID wards, but those were utilized, and with justification and with no apology, because we had to save those lives, those Jamaicans. The ventilators similarly so. So for those 2 years, the infrastructure was utilized to support, with the consent of the European Union and the government, as a response to COVID. Since the declaration of COVID no longer being a national threat, we have gradually reintroduced the Promac infrastructure to its original intention. And that's very important to note, because it required a transition in a number of ways. However, since that period, 2022, and that conversion started, and hundreds of Jamaicans have benefited from the Promac infrastructure and the Promac equipment. Indeed, I have some data here coming out of the regions. 1,345 patients have been served by the Promac facilities in the last financial year, 23-24. And this figure does not include other critical patients who have needed critical care. In the Northeast region, 92 pieces of equipment was provided to the St. Anne's Bay Hospital, with 16 at-risk mothers being served, 259 babies receiving support through the facility. The Southern region, 29 pieces of equipment from Promac. Last financial year, 633 patients in the state-of-the-art facility benefited from the program. And in Spanish Town, 10 mothers, 314 neonates benefited from the facility, and they received 26 pieces of equipment. These are lives, real people, mothers who develop significant complications, babies or neonates who had complications. The system, the infrastructure worked for them. It saved their lives in most instances. And so it is very unfortunate that an insinuation is made that somehow this expenditure went to naught. In the first phase, it saves hundreds of lives of Jamaicans who were affected by COVID, with a rescoping that was necessary at the time. And in the second phase, clearly, it is now being returned to its original use. Now, it's important that we are mindful of this context before we get into the rhetoric that gives a false impression, because it undermines the credibility of the partnerships that we have established. And I'm happy that the European Union is now of the opinion that those who have spoken negatively about the program are suggesting. But this segues into the third issue, which I suspect is why this Promac issue came into the spotlight, which is the maternal health of our country. And the numbers that we in public health put out in our vitals, we are the one who published this to say to the country, we have an issue, a challenge that we have to take on. Nobody discovered it. We put it out, and we're happy to discuss it, because I think it requires ventilation, for want of a better word, or conversation. So yes, it is true that there have been an increase in maternal deaths. And I'm going to ask the CMO to comment on this, both from the standpoint of what has been the challenge and what is the response, which again is captured in the documents that we have tabled. But just to say that COVID brought significant side effects to maternal care, and it's not unique to Jamaica. Indeed, the global figures suggest that maternal mortality went up because of the COVID pandemic. And we were as much victims of that as the world was a victim of this, the COVID virus. It wasn't just about the virus, it was about late mothers turning up late, for example, chronic illnesses that have not been treated or controlled, which made the pregnancies more risky, and a number of other issues. We have accepted that as part of the side effects of COVID, just as we did mental health, and we are doing interventions to correct that. So I'm going to ask the CMO now to just speak briefly to this issue and how the government has sought to approach this, which includes recommissioning the Promac facilities for its rightful purpose in a post-COVID environment. CMO.
Thank you, Minister. So just to put in context, we have just above 30,000 births each year. And the Sustainable Development Goal is that we try to achieve less than 70 maternal deaths per 100,000 live births per year. And the target is to get there by 2030. Now, Jamaica has not been doing so well where this is concerned. In 2019, we had a rate of 163.5 per 100,000, and in 2021, with COVID, we went up to 211 per 100,000. We know that we had associations with poor outcomes and pregnancy, and just like the rest of the world, where the numbers in terms of maternal deaths increased, our numbers also increased as we had a number of antenatal patients who did suffer from COVID and had poor outcomes. And that resulted in that spike in our maternal mortality rate in 2021. Post-COVID, we are at the level in 2022 as we were in 2019 with 161 per 100,000. And then in 2023, our numbers have declined a bit. We're at about 130. So we are trying to get to the 70. We have put in several efforts in order to reduce the maternal mortality rate. I want to say, though, that the major causes of death in this group are hypertensive disorders of pregnancy and postpartum hemorrhage, bleeding after giving birth. Now, we have seen over the last couple of years that our incidence of non-communicable diseases have increased and continue to increase. And this affects our pregnant mothers just the same, because the number of mothers with chronic diseases are also increasing. And so therefore we have risky pregnancies. And so we have a risk to the mother and a risk to the child. And so in terms of antenatal care, it's very, very important for mothers to recognize, or persons who intend to become pregnant, to have children, to prepare themselves for pregnancy. We have focused for a long time on, contraception and reduction in rates. But in terms of the mother's readiness to become pregnant, we have to focus on that to make sure that chronic diseases are controlled and that persons are physically well and mentally well in order to manage a pregnancy. We have also seen over the last couple of years a rise in unhealthy diets, And our health promotion programs or nutrition programs are targeting this quite a bit, starting from in our schools, and as a matter of fact, starting even farther back in terms of in utero, in trying to address the mothers in the antenatal clinics. Because what we're finding is that these unhealthy diets, we have a large number of persons that are anemic. And anemia in the pregnant patient can give rise to poor outcomes, such as problems in terms of bleeding and in controlling bleeding. And we see that this is a very predominant cause of deaths in this group. So there are issues that we have to manage as well in terms of antenatal care, in terms of making sure that the mother is healthy and ready for pregnancy in order for us to have good outcomes both for the mother and the child. And this would have contributed significantly, as I said, to our increased maternal mortality rate. So the tackling of NCDs efforts need to be there in terms of antenatal care. So we find that when we look at our maternal deaths, we have problems starting from mother not seeking care in time. So there's a delay in the mother getting to care. And then we also have problems once the mother comes into care, that there are sometimes delay in interventions. Now, the Ministry of Health has been working to try to address these two major issues. We are launching an antenatal campaign so that we can educate persons in the general population about pregnancy, so that this thing in terms of when you are ready to become pregnant, that this is planned. So you are looking after your health, you're looking after your nutrition, and you're looking after your mental well-being to make sure that you're in a good position. We also want family members, community members to participate in ensuring that mothers seek antenatal care, that they look after themselves during pregnancy. Anybody knows that anybody is pregnant, to insist, to put in a word to say, are you eating properly? Are you taking your iron tablets? Are you looking after your chronic illnesses? So we want a campaign, and we are launching this campaign to educate everyone about pregnancies and the problems that can occur, so that we can better prepare not just the pregnant mother, but the family and the community to care for the pregnant mother, to lead to a better outcome, leading to them seeking care when they have problems, recognizing problems that occur. And this is critical in terms of ensuring that they visit their antenatal clinics and they're sticking to the schedule at the clinics. They're not missing their appointments, so that they can be educated about what to expect in the pregnancy, what not to expect when something is abnormal, so that they can recognize and seek care quickly. We're also doing a lot in terms of improving the capacity within our hospitals. Minister would have spoken about the Promac program and the different types of training that would have been put in place to equip our primary care providers or specialists in hospitals with more knowledge to care better. The equipment that has been put in to be able to monitor the pregnancies and to be able to intervene, and the infrastructure. But in addition to that, we are looking at all our clinical guidelines. Where clinical guidelines would not have existed, we have created those guidelines, we have reviewed guidelines, we've updated guidelines, and more importantly, we are training and continue to train our healthcare workers on these guidelines, so that we can have more immediate attention when the mothers get into problems, and that we can save those lives. So these interventions are being put in place to improve, with an effort that we are trying to reduce the maternal mortality rate to get to that 70 per 100,000 live births. And all the efforts are being put in place there. So, Minister, I think those are the areas that you would have wanted to focus on. Again, to say that, yes, maternal mortality is something that's a class 1 notification. So as soon as a death occurs, we investigate it, We try to find out the causes, and we are working to address those causes so that we can reduce the rates.
Thank you very much, CMO. Okay, so I think hopefully that is a lot clearer. And just to reiterate, firstly, that the issue is an issue, and we have never denied that. We have put it out in the space. It's not unique to Jamaica. COVID has been a great contributor to this, and therefore what we have to do, as all other countries are doing, is to redouble our efforts. And the data does suggest the increase did take place during the COVID period. And there is a program to support overcoming this issue, which I believe will work and is working. And we can elaborate more on this if necessary. I want to just address one other issue, and then we can take questions. There's a tendency to be hyperbolic or exaggerate by the opposition the issues in the health system, almost as a sort of scare tactic to serve what I consider to be narrow political ends. And it's rather unfortunate, because it really doesn't do good to any of us. I have never denied, in fact, I said it in my sectorial, that we have solved all the problems. Problems evolve, they occur every day, and it is our desire, as public servants in health, myself and the government of the day, to address those problems. And we have been very deliberate in addressing those problems. And I'm prepared to debate this any day, any night, anywhere. So I try to stay clear of doing damage to a process to serve my own ends by being hyperbolic in describing the system as in crisis or near crisis. The truth is that this is nonsense. And I say so without fear or favor. And I say so respectfully, because I do appreciate that the opposition has a role, and part of that role is to object. But we have to be fair to the people of Jamaica. And even with the concerns that they have, and they are well entitled to have concerns. There have been concerns about Falmouth recently. I believe Dr. Frazan and the CMO, she can provide any questions that you may have, Maypen, because these things happen from time to time, and there is a process. And we must always show empathy to family members, to loved ones who may feel aggrieved and may require clarification, support of one form or another. But beyond that, there's no doubt that the system is far better today than it was 8 years ago, 5 years ago. And it's better from a number of perspectives. And it is wrong. It is hyperbolic. It is misleading and dangerous to give the impression that somehow the system is near crisis. And the evidence is there. I mean, on a financing budgetary standpoint, this government has moved the budget for public health from 60 billion to 145 billion, 241% over the 8-year period. That kind of increase has never happened before. You may ask, okay, where is that budget? Well, 2016 capital expenditure was 4.6 billion. It's now 11.5 billion, 246% increase. That is why if you visit Spanish Town Hospital, you see the foundation being dug out for a 6-story building. That's why we will have a brand new Cornwall Regional, because we have stripped it and are building back a new hospital. Our contribution to Western Child and Adolescent, even though part of that is the Chinese government, the announcements to come around St. Anne's Bay and Maypen, the many health centers, all of this capital expenditure, which is seeking to put health back on track in keeping with the population increase and the sick profile of the population. This kind of assessment and deliberateness has never happened before, and it is inaccurate to suggest that somehow, with all this effort, the system is in crisis, despite the challenges that we have. If you argue on the basis of human resources, the ministry has expanded the cadre of healthcare workers to over 1,400 new posts for doctors, which are being filled. 1,400. Which other administration has expanded new vacancies and permanent posts to that extent? That's not a system that is crisis. That's a system that's responding to the inadequacies that existed before. The ministry has created over 2,400 positions for community health aides and provided them with security of tenure, no longer on contract, permanent posts. These are the people who go into communities, who visit families, who provide health information, who help them with basic treatment, who are supervised by the public health nurse and doctors. And this is part of the reform of primary health care that is now taking place. That's not a crisis, that's progress. That's expansion. That's right-sizing healthcare to address the concerns. The collaboration with Cuba has been ongoing and strong, started before our time, but we are now adding to that Nigeria and the Philippines, because there is a recognition that we have a shortage of critical care health workers. And that shortage, we can argue that it's not just because of our inadequacy in training or lack of training, because training requires faculty, clinical rotation space, but there's a mass recruitment because the world faces a shortage. We are now making steps to deal with that. We've announced a scholarship fund that you'll hear more of next month, the largest funding of public health training since independence. And I make no apologies for that. That's not a crisis. That is progress by this government to right-size public health in terms of human resources. And we have created some 2,000 posts for nurses and continue to expand our training to health staff with our scholarship program, as said earlier. In the area of infrastructure, we have 220 beds coming on stream next year. I heard the opposition, again, very hyperbolic and exaggerated in his claims about the Western child being a white elephant, likely. Didn't bother to ask the questions as to what are the structures that have been put in place to equip Western Child and Adolescent Hospital. We have already appointed an SMO, a CEO, HR person. We already have an HR plan that they are now working towards 1 full year before the hospital is slated to open in May of next year. That's not a reactive position. That's a planned position. That's not a crisis. That is progress being made by an administration that knows that when it builds an infrastructure, it has to equip it. And even with the shortages and the concerns, we're putting in place measures either to train them locally or train them in collaboration with other institutions, as I've outlined, places like the Philippines. So Western Child, Spanish Town expansion will lead to 100 new beds, 6 new operating theaters, CT scan, MRI being provided. Our investments in Cornwall is because of a 30-year neglect. I know that's an Achilles heel for the government because a lot of people expected that it would finish much sooner. COVID intervened, and for 3 years, not much took place. But when it is finished, it will be a brand new hospital. Every piece of equipment in Cornwall, at Cornwall Regional, will be new. The team just came back from China where they did a full assessment, and they are now putting in the internals. And every window will be new, every door, every ward space, every bed, every ventilator, every operating theater. There'll be 7 at Cornwall and 5 at Western Children. That's 12 operating theaters, all brand new at one concentrated location. That's not a crisis. That's progress that this administration has committed to. And then there's electronic records. Never ever happened before. In another month, we will go live at Spanish Town Hospital, where records are going to be digitized, which will improve the flow of work for a patient and for the practitioners, because we will digitize and move electronically the patient information from one place to the next. Already MAPEN is online. We're now bringing in the health centers in and around MAPEN Hospital. Spanish Town is next. That is not a crisis. That is progress by an administration that has committed resources to improve what has been a very neglected area over many, many decades. And I could go on. I could speak to the other issues, the leasing of equipment that is now taking place, and other programs that are in effect to address the challenge. This does not mean that we do not have challenges, and we've never, ever said that there aren't challenges. This does not mean that challenges will pop up from time to time. The issue of patient relations and showing empathy and treating with patients especially when they are grieved over an incident, is something that we need to take seriously. And we're establishing a new unit in the ministry to troubleshoot those issues of concerns and to come up with recommendations and solutions for them. And so it's always a work in progress, but it is inaccurate, it is misleading, and indeed I dare say, because those who have ears to hear and eyes to see should know and know better. It is mischievous to suggest that somehow the health system is in crisis. We are in a better place today than we have ever been, and we are very proud of it. And we will continue to do the work to ensure that the system works. Okay, so this has been an attempt to address some of the outstanding issues that have been making the rounds in the news in the last week or two. And I hope that it would have clarified some of the issues. I think we should take questions now. I mean, I didn't raise the Falmouth or Maypen situation. Those have been ventilated a lot, but the team is on, the technical, clinical team, if there's any need for elaboration, without divulging too much on patient confidentiality. So let me close here, hand back to Stephen, and have Stephen address the questions in the room. Thank you.
Thank you very much, Minister. So I'm inviting our media colleagues on the Zoom to use the raised hand feature to pose your questions to the team. Just please introduce yourself once you are identified. And we're going to begin with Kimon Francis.
Good morning, Kimon Francis from the Gleaner. Specifically to maternal mortality rates. In 2017, the rate for the Southern Regional Health Authority was 26.8 per 1,000 live births. In 2022, it moved to 273 per 1,000 live births. What accounts for this? Because I'm looking at the data and I'm seeing 11 of the 19 COVID-related deaths in 2021. There were 11 of 19 COVID-related deaths in 2021 and 2 of 18 COVID-related deaths in 2022. So it says that there's a big problem in the Southern Regional Health Authority.
We would have looked at those figures ourselves at the ministry, and we have been engaging the regions on a one-on-one level to try to strengthen their response to maternal mortality on a whole. We know that the southern region did see a bit of COVID-related maternal deaths, and that even though some of you're not going to have all the details in terms of what is happening to the patient, but our discussion with the southern region did show that there was some overflow into 2022 in terms of problems resulting from COVID. But in all the regions, we have taken a very deep dive into what is happening to address hospital by hospital, how it is that we can strengthen their response. I think the dialogue so far has shown that there is renewed commitment in terms of trying to bring down these rates. We do have a very big problem in terms of the antenatal period, because I said a large number of our deaths are due to hypertensive disorders in pregnancy and postpartum hemorrhage. And so we are trying to address those. Our campaigns in terms of promoting healthy lifestyle plays a big part. And as I tried to bring it earlier to say that the antenatal, the mothers are being affected just as well. So in all the regions, we are looking at those numbers, and we have a detailed investigation of each death, and we are trying to strengthen the response in every hospital.
Thank you, CMO. We're going to go to Siobhan Wayne Campbell.
Stephen, while we wait on...
Hello, good afternoon.
Okay.
Yes, good
Sorry
morning.
about that. I wasn't unmuted.
Go ahead, please.
Just two quick questions. The first one is a simple statistical check. Exactly how many high dependency and intensive care beds do we have across the country, and what is the expected average per capita in terms of global average?
Prior to COVID, when we had done our checks, we had between 20 to 30 high dependency intensive care units. Our initial thrust at that time was to put in an additional 40 spaces. Now, during that period, and we would have expanded since that in terms of the numbers of equipment that we would have received. What we did not get was the complementary increase in the number of staff to operate these areas. So we would have increased the capacity, for example, at Mandeville Regional Hospital, at St. Anne's Bay Regional Hospital, at Cornwall Regional Hospital, even despite the challenges that they faced, and at Bustamante and KPH, Victoria Jubilee, we would have brought in some of the Promac spaces. We have not, even though we have the ventilators, we would not, our maintenance of the HDU and ICU spaces is dependent on having the staff. And so you will find that we expand and then we contract. I have, for example, Bustamante Hospital that have 5 intensive care beds, but more frequently than not, they are nursing 7, 8 patients. Because where it is that they may have a ventilator, then they will try their best to accommodate additional patients. The same thing with Kingston Public Hospital, the University Hospital. All the hospitals, they may have a dedicated number, which we would say is their routine number. But when it comes to emergencies, yes, they have the ventilators there, and they may have to try to find ways and means of monitoring these critically ill patients. So it's hard for me to tell you an exact number of HDU, ICU spaces because it fluctuates. We do have additional ventilators, and it would be good to say that we have that amount of HDU, ICU space, but it is not in fact so. We need everything to have this space in place. And, for example, Mandeville Regional Hospital would have created 2 additional 2 spaces in their recovery room for ICU, and it is, you could say that they have a 2-bed HDU. During COVID, they would have converted a part of their medical ward to be able to accommodate 4 high dependency patients, but then they would have had to contract back down from those spaces because they would not have the necessary staff, and they need that bed space to accommodate the regular medicine patients. And many of our hospitals are in that position. They may have the capacity because they have a ventilator, but they're not able to offer that care because they do not have all the staff in place. And so the number tends to fluctuate from time to time.
Thank you very much, CMO. We're going to go to Jamila Maitland.
Hi, good morning. Jamila here from TBJ News. If the minister could just clarify the number of ventilators. I heard 210, then 118 active, 40 being maintained, others waiting on parts. Is that 40 including in the 210? And are we saying how many are just out of the system in general?
Okay, let me just read from the script to be clear. So there are 210 ventilator registered, the tangible assets registered. Of that number, 118 are in active use up to the point of the audit, which was completed, I believe, yesterday, and fully functional in the system. And then that would leave 92. 40 are out due to maintenance related issues. And there's routine stuff that takes place. Some may come back in the week after. There are some of that 40 that are waiting on parts. That may take a little longer. The rest, so that's 40 minus 92. So that would be 52 would be considered obsolete. And I by the way, I requested that they give information on every single piece that they have, including those that are old, outdated, because we do have a system of, I don't remember what you call it, maybe PS can help me, where they have to be commissioned and taken out with a validation process and so on. So if you go to any hospital, you're going to have a whole heap of storage of beds and wheelchairs and so on that are stored, that are not used, are outdated, but are on record or on file. So I just asked them to give us everything because of the public issue of it. But just to be clear, 118 are in active use and 40 at the time of the audit would be requiring some sort of servicing. And I also said that the 118 is more than adequate and represents the highest number of active use ventilators in the public health system. And I'm clear on that. So I hope that clears it up. Thank you.
Minister, just to offer a little bit more clarity, while it is that we can give you a number for those for ventilators received into the system, it's always difficult to give you an exact number of ventilators that are working, because this week I may have 5 ventilators out and I may be able to get 3 of them up by next week. And this happens right across the hospitals. The ventilators are used continuously sometimes, and sometimes they do have to be taken down for repairs. And so while we can say we have X amount in, we know that X amount are definitely not working, and there are 118 that are working. I would say working in this period of time, because tomorrow I may have ventilators that are down. And then I also want to add as well that in terms of ventilators that are working, we use ventilators in the operating theater as well as in the intensive care and high dependency units. Some hospitals will have ventilators in their recovery room that they may need to support a patient until they're able to breathe on their own. So this number 118 would include all of those ventilators and not just the ventilators that are there for high dependency or intensive care. So I see some numbers being band around 60, 70 numbers in terms of being available for ICU or HDU care. But we do have, maybe about 20 hospitals with operating theaters. Don't quote me on that. But many of the hospitals would have more than one operating theater, and each of those operating theater would have a ventilator as well. So the number is including the ventilators that are in the operating rooms, and the numbers available for ICU and HDU would be lower and tend to fluctuate very frequently. Thank you.
Thank you very much, CMO. We go to 18 degrees north. All right, we'll come back, not getting through. Kimo, you had additional questions? Kimo and Francis?
Yes, I'm here, guys. I had to unmute. I'm here. I'm fully here. Can I go?
Yes, please go ahead.
Okay, I said good morning. I am asking today about a story I ran very early last year, right? This would have been around January, February period, right? Where 3 babies had died at Black River Hospital in St. Elizabeth in January alone, when for each of the past 3 full years, there were between 5 and 7 such deaths, right? Additionally, I had called around to various hospitals and had learned 3 had also died at Savlamar Hospital in Westmoreland compared to this time the previous year, right, when there was only 1 such death. This was back in 2023, as I said, that this story ran. And I never did get an update officially from the Ministry of Health regarding this report that I put out about why it is that these babies, what was the official reading about why these babies had died in Black River and also in Westmoreland last year, again around January or February.
Okay, that's a very specific question that is going to require for us to pull specific information. I really don't have that information here with me. I can't say what was the result, if any, in terms of investigation. But as you raise that point of the time period, I really want to point out to persons that we are in a very critical period now. Our increase in births tend to happen at around September. And usually June, July, August is where we see an increase in the number of premature deliveries. And so this period of time is very critical in terms of antenatal space, in terms of maternal mortality rate, in terms of neonatal care, especially neonatal intensive care. So we do come under a lot of pressure at this time. And if you look at trends, then you will see that this is a very worrisome period. And so therefore, we have had our meetings with our hospital staff, or referral centers, in terms of, shoring up their capacity and to put measures in place to ensure that we are doing as much as we can. But there are some instances that it is really difficult because, as we have problems in terms of mothers with chronic diseases and problems that really makes the pregnancy very vulnerable. And when you have a baby being born at 28, 29, 30, even 31 weeks, it's a very vulnerable state that this neonate is in. And, every effort is made in terms of trying to increase chances of survival. But again, I really want to take the opportunity to emphasize how important the antenatal period is so that we can get the mother to a term pregnancy and to be able to deliver a healthy baby. Because when we have a sick mother and we have a sick child, then it really takes a lot of effort, and it really is dependent a lot on the ability of these sick patients to be able to pull through in response to all the supportive measures that are being put in place. Now, I'm not sure what had happened in January 2023 or the cases that would have been if there were any similarities between the cases. But as you mentioned, a time period, I really would just want to highlight that this also is a very vulnerable time, and every effort must be placed in terms of making sure that our mothers are healthy so that we do not run into having these vulnerable babies being born, which really is, makes it difficult sometimes to increase the chance of survival. Thank you.
Thank you very much, CMO. I'm going to go back to Kimon Francis.
Three-part question for the CMO and one for the permanent secretary. CMO, how many pediatric ICU ventilators are in Jamaica? How many neonatal ICU ventilators are in Jamaica? And specifically, what support has been given to the Southeast Regional Health Authority to support doctors in training complex airway disorders, which would reduce the need for ventilators? So that's for the CMO. And for the permanent secretary, why have you failed to submit the appropriations account to the Auditor General?
All right, Kimon, you keep coming back to your numbers, and you're not getting my message that I don't want to commit because the numbers keep changing. But what we will do is we will publish the numbers that the capacity that we have, bearing in mind that we're not always able to use that capacity because of other challenges. And many times, many times, thanks to the efforts of the healthcare workers, we go beyond that capacity in offering more. In terms of the question, in terms of training, training of doctors to handle complex airways, we do have continuous training that is going on, and we are trying to vamp this up in terms of our resuscitation courses. We have a course that is called the Pediatric Advanced Life Support course, which is a very helpful course in terms of responding and managing those critical issues that happens to the babies. And so we are vamping that up. Recently, we've had a challenge in terms of getting the equipment in place to be able to go full course with those courses, but we are getting things in place to do that. But in terms of the general training that is being done, I mean, we do support our doctors in specialist programs. We do support our doctors in specialist programs, and there are courses that are being run in terms of from the ministry's training program in their different programmatic areas. There are efforts to increase the training that is there in terms of not just airway management, but also in management of things like postpartum hemorrhage, in terms of managing the complications of hypertensive disorders, etc. So we do have a lot of training dependent on the program that you are looking at, and this is a continued effort. Our doctors are required to do continuous medical education in order to be registered each year, and the same for our nurses as well.
All right, thank you very much for
can I sorry, Pierce, before you come in. There's a journalist that's online, Stephen, that was asking a question about ventilators. Apparently not getting through, so I just asked the CMO to comment on it. I think they wanted to find out this concept of pediatric ventilator or neonate ventilator as opposed to adult ventilator, the settings, and maybe for clarity, just explain that ventilators can serve different purposes. So you could have multiple settings or narrow settings, which explains why you may have a ventilator for an adult population and not necessarily one for a pediatric population. I think there needs to be a little clarity. And since, as a clinician, maybe you could comment on that.
I don't have all the information where this is concerned, and the anesthesiologist would be in a better position to answer that. However, we do have ventilators that come with different settings, whether they're settings for the adult population, pediatric population, neonatal population. And so we are not always able to move around ventilators because we have one particular ventilator in it may not necessarily have the wherewithal to manage a neonate who would have much more delicate respiratory issues. So we can't move them around like that. it depends on what the ventilator has the capacity to do, the type of age that we're able to use it in. So I hope that can clarify the question. But if more details on that are needed, then I would ask them to be directed to Stephen, and so we could get a more detailed response from our experts in that area.
All right, thank you very much for the question. And to answer this question around the submission of the appropriation accounts to the Auditor General's Department. Now, recall that we went to the Public Accounts Committee last financial year, on this very matter, and the Ministry of Health and Wellness developed a plan of action around the right sizing or the regularization of our reports. However, at that meeting, the Ministry of Finance did indicate that the issues relating to the legacy system, which is the financial management, the FinMan system, which is a legacy system that supports the transition to the central treasury management system that we have now. Now, in that legacy system, we still have some challenges, and up to April of this year, we wrote to the Ministry of Finance outlining the challenges that we have in relation to the legacy system, FinMan. Now, it's over 10 years worth of records from 2013 coming to 2023. So 10 years worth of records that are outstanding for the financial submission to the Auditor General's Department. Now, there are several other issues relating to the submission of the report, and you would understand and appreciate that because it's 10 years, a lot of data has to be gathered from these years, and some of the data is in manual form, and because they're in manual form, the access to that data becomes challenged. And so we have several issues that have resulted in our inability to provide the reports, one of them being the FinMan system, to which I have outlined before. Other issues relating to missing records from our financial documentation from 10 years ago, the appropriation in aid accounts, some of those data is missing. And one of the major issues that we're having now is that officers within this particular setting are being asked to sign off on information from many, many years in the back. And some of the officers are unwilling to sign off on transactions that they are not a party to, because the persons who should be able to sign off on these transactions are either overseas and cannot be located or have passed away. And so it requires us to try and arrive at different remedies. Thank you. Different remedies to adjust for that. The appropriation accounts are very, very important, and the Ministry of Health and Wellness is seized with the importance of they are a critical part of the accountability matrix for the government of Jamaica. This is a large ministry. A lot of the transactions that we have to do cover thousands and thousands of records, and you will anticipate that 10 years in the back of records is a bit of a challenge. At the beginning of this process, we set up, as I said before, a project to bring us up to date with the appropriation accounts. Already, I've spent over $40 million in overtime and overtime payments for the regularization of the appropriation accounts. We have regularized the Bellevue Hospital, and we have also regularized the government chemist department. We are regularizing within the next 2 months, financial years 2020, 21,
21, 22, 22, 23. However, the backlog months are where we have the significant challenge. This is a problem across different administrations, and as was pointed out in the Gleaner article, this is a problem that has existed within government for over 30, 40 years. So it's not new to this ministry, and of course we try our very best to attack it frontally because we understand the importance of providing these reports. Again, the Ministry of Health and Wellness is committed to bringing these accounts up to date because we are committed to transparency and accountability in how we do business here in the ministry. Thank you.
Thank you very much, Pierce. I believe Kimon Francis has a follow-up question for you, sir. Kimon?
Yes, said Greener article, which my colleague wrote, said that the Health and Wellness Ministry reported early last year that the appropriations account for fiscal years 2013 to 2014 to 2022, 2013, 2014 to 2022, 2023 had been completed and submitted to the internal audit unit of the ministry for verification. That was a year ago.
That's absolutely correct. So they were completed and submitted to the internal audit unit. But if you understand the process, the internal audit unit receives the accounts, but they have to do the verification. And it is that verification that is causing a lot of the issues, because the auditors are saying this particular transaction was not signed off on in 2020, in 2014, for example. We need it to be signed off on. Sent back to Finance and Accounts, then Finance and Accounts is asking the current holder of a particular office to sign off on it, and that person is saying, I know nothing about this transaction, I cannot sign off on it. Then it has to go now. So who was the person in that post at the time? And in some instances, the person who was in the post at the time has passed away, or that person, when we try to locate them, are somewhere outside of the island and we are unable to reach them. So those are the issues. Then there are other issues now where, for example, the legacy account, which is the Finman account, produces a report where when we send it to the auditors are saying, look, the Finman has given you a report from the system, but it has missing data in the general ledger. And the general ledger control accounts are incomplete, so we cannot certify this statement. And so when we go to Finman now to pull down the missing data, the data is not there. And so we wrote to the Ministry of Finance to indicate to the Ministry of Finance that this data is not present in Finman. So we need to get it because the auditors are unable to certify because of the missing data. And the missing data from 2013 to 2018, we have accounts history of $34 million missing. Trial balance of $34 million missing. The FS6 statement, the appropriation statement, there's differences in the statements of $4.4 million in one transaction. So because the data in the software is not complete, is missing, the internal auditors cannot certify the transaction. And therefore, because they need to certify, we are at a stalemate. So we have written to the Ministry of Finance to have a conversation around what we can do in relation to Finman to enable us to submit the reports in an appropriate form. Am I clear?
All right, thanks. Yes. All right, thank you very much, PS. I'm going to go to Jamila. You had a follow-up question?
Yes, thank you, Stephen. Just a comment for the CMO when the document is to be released. I'm hoping that you could just differentiate the ventilators that are just open to the public rather than those in the operating theater. So if a regular person comes in, then they'll be able to get that. And 2, in light of the death of the baby at the Maypen Hospital, what changes, if any, has been made to ensure that the equipment is there and our staff is trained to ensure that as best as possible, we don't have an issue like this happening again?
Okay, we'll ask Dr. Bradley Edwards from the Maypen Hospital to respond.
Okay, the question was asked, what measures are being put in place to ensure that what happened has not happened again? I just want to see clarification.
Yes, that's it.
Okay. So up to this point in time, we've had to take a regional approach to coming together to form a solution. The regional approach is that we had a meeting yesterday morning with the regional hospital, Maypen Hospital, Black River Hospital, Percy Junior, all the different hospitals came together to come up with a solution to see how best we could handle a situation like that may arise. As has been expressed before, the management of a patient with respiratory distress must be managed by a team. And having a ventilator by itself is not where it begins and ends. The team currently, we have about 2 critical care trained nurses currently who are capable or have been trained on managing ventilated patients. At this point in time, we now need to work on the medical side, which is ideally managed by a neonatologist. And I do believe that perhaps in the future we need to try and acquire such a person. But in the interim, we will be training our doctors to see how best they can get up to speed in terms of supporting the team, which is critical nurses and doctors, in managing patients who will need respiratory support, especially in the neonatal area. Thus far, we have had to be managing in the adult population patients that have come in. We have a critical care trained doctor who deals with adults who, when those cases come in and we have difficulty transferring, we have support on the ground. But I'm not sure if that is the answer to the question, but that's it.
Thank you very much, Dr. Bradley Edwards. He is the Senior Medical Officer at the Maypen Hospital. I think this may be our final question. We're going to go to 18 Degrees North.
Hi, Stephen. I'm asking you not to mute me after the question because I think this one could have been addressed at the time when I was first asking the question, but I think you muted me and then went to the next reporter. So I'm asking you not to mute me even after the first question because this is about maybe 2 questions here. Okay. All right. So just another thing. I had mentioned to you in my last question, Dr. Bisesa McKenzie, about the neonatals that died. There were 3 babies that died at Westmoreland Hospital, Savlamar, and also 3 at Black River, right? And you said those are very specific cases, right? And so you don't have the report at your fingertips. Now, I asked you at the time I was reporting last year in January, I asked you whether or not, I think it's in a WhatsApp message, whether you were investigating it. No comment from you, right? Now, I bring up the neonatal thing because being in touch with the opposition regarding their complaints about the health sector, one of the things that one of the persons on the opposition side has pointed out to me, right, which is more recent to obviously my thing last year, was that the number of annual live births per thousand population was 11.4 in 2022, right? And that compares to the number of live births per thousand population being 21.7 in 2000. So there you have a full drop off there in the number of live births since 2000. But at the same time, you have a mortality rate among neonates going from 9.2 per thousand in 2000 going to 14.6 per thousand in 2021, which is a 57% increase in mortality rate. Infant mortality rate, I was just trying to get the figures before coming up here, right? Let me just see here, 13.2, let me see if I can just pull it up real fast. 13.2 in 00, right? Infant mortality rate goes to 14.6. Am I reading that right? Hold on one second. Sorry. No. 13.2 going to 17.7, it seems like. So that has also increased, right? If I'm reading this right.
You have a question, Sarah? What's the question, please?
Sorry, the question is, I think I'm reading the tables wrong because they're on my phone, so I apologize for this, okay? But the point I want to make is that how can we be having so much fewer births, right? And yet the mortality rate is so much higher, right? As I say, I might be wrong on my calculations about the 57% because of how I'm reading the table, but I'm just asking a question. What is the reason why we're having fewer births and yet a higher mortality rate among the ones that are being born? That's what I don't understand.
Okay, yes. Okay, so I'm not the specialist in this area, but I'm going to try my best to answer your question. Just to say that in the quotation of the rates, the infant mortality rate and the under 5 mortality rate are influenced by the neonatal mortality rate, because the neonatal mortality rate is a subset of those other groups. So the rise in the neonatal mortality rate is what affects the infant mortality rate and the under 5 mortality rate. Now, what you will find is that the reasons for death would have changed. You're going to find that as technology advances, and we tend to babies that would not have had a chance of survival in 2000 would have more chance. We have more interventions. We're not able to save all of them, but certainly you would find that we are able to do better with our premature births than we would have done in 2000. However, you're going to find that with the increase, and I tried to explain this earlier, in terms of the other factors that are affecting the pregnant mothers, in terms of the rise in or hypertensive disorders in pregnancies, for example, or diabetes in pregnancy, or mothers are choosing, or women are choosing to have births later. And as it is that women get older, then they're more likely to develop chronic disorders, which puts not just themselves, but the babies at risk. And I pointed out as well in terms of the nutrition, in terms that we're not paying attention as we used to some of the nutrition issues. And so we find that we have a lot of women who are anemic. We also have a problem with obesity. Overweight and obesity is now 1 in 2 in our population. 1 in 2 persons are either overweight or obese. that BMI level affects the pregnancy as well and affects the development of disorders that leads to premature deliveries, that leads to smaller babies, low birth weight babies who have a tendency not to do so well. So there are many epidemiological factors that have changed, and there are many demographic issues that have changed that would have contributed. Now, earlier I said we have recognized this, and this is not something that is good. And I mean, it's something we have a discussion about almost every day, in saying, how do we bring down these numbers? I mean, as I said, going into this June, July, August period, we would have had that discussion with our hospitals. What is the extra that we can do? How it is that we make sure that none of the problems that we would have encountered in previous years, we have those problems again. So we are trying. We recognize the problem. It's very, very glaring for us. We recognize the factors that can contribute to it, and we are working. I am hoping that our antenatal campaign will be launched very soon, and that will, just increase the awareness of persons in terms of when they're ready to get pregnant, but not just only the mother, but the persons around them to support the pregnancy. I mean, we still have persons that are showing up within the last trimester to deliver, or showing up at that time to visit the antenatal clinic. We still have persons that start out well and they have 1 or 2 antenatal visits, and then they don't complete the antenatal care. So we have a lot of issues, and we are trying to address this. Our family health unit or health promotion unit, or units that address the risk factors associated with NCDs, are all working, gearing towards trying to get a healthier population, because this is what is going to impact the outcomes, not just generally in terms of our mortality and morbidity rates, but our maternal mortality rates and our neonatal, infant, and under 5 mortality rates.
All right. Thank you very much, CMO. That's all the time that we have for questions. For additional questions, you can always reach out to us via email, and we have those responses to you. As we close, I'm going to hand back to the Minister for his closing remarks.
Thank you very much, Stephen. All right, so I just want to take the opportunity to thank the team for coming on, the CMO and the PS, Dr. Bradley, and others who are on, for participating in this conversation, and to the media, of course, for coming on and for asking your questions and listening to the comments on each of the issues. I think it was a good discussion. I think it's important that these opportunities are allowed to clarify and to address concerns. And we have no issues with the probing questions. We try to provide as much information as possible and allowable under the patient, client privilege, confidentiality guidelines. I want to say too that we may have to do this more frequently, because I think there is a lot in the air. It is a season now to probe and sometimes to exaggerate some of the issues that are occurring. I am not, as the only politician on this platform now, unmindful of the political season. And so you're going to get a lot more of these insinuations and claims and counterclaims. It is not our intention to get into any sort of sustained argument over he said, she said. Our desire is to provide the information as we have it, and we've tried to do that this morning by putting this information out, by recognizing that we have put information out in the past, and that we're providing whatever information that is required to clarify or to address the issues. And I think there's going to be value in doing this on a periodic basis to avoid any mischief, misinformation, or misunderstanding. We continue to try hard to address the public who use our health facilities. Just bear in mind that we see over 3 million visits each year between primary healthcare and hospitals. We see over 200,000 admissions. There is a margin of error there, and there are going to be complaints. Our complaints levels are well less than 1%. And we're going to have to try harder to deal with each complaint. So that is our commitment to the population, to the Jamaican people. And we will continue to work towards that. So thanks again for coming on, and we will continue the conversation, if not in this way, outside of this forum. Just supply us with your questions and we'll try to provide answers. Thanks again. All the best.